webinar series. So today's spotlight is actually on hemodialysis. The title of today's webinar is Expanded Hemodialysis and the Clearance of Large Middle Molecules. Before I turn it over to our speaker, I did want to take just one moment to bring your attention to the bottom right-hand side of your screen. We will be using Pigeonhole today for questions throughout the webinar. So please take a moment, grab your phone, and log into either pigeonhole.at or use the QR code and be prepared to enter your questions into the Pigeonhole. Our faculty presenter today is Dr. Marcos Rothstein, and Dr. Rothstein is a professor of medicine in the Division of Nephrology at Washington University School of Medicine in St. Louis, Missouri. Without further ado, I am going to turn this presentation over to you, Dr. Rothstein. Thank you so much.
Thank you so much, Stephanie. I think it is my privilege to bring this very, very consequential discussion today from St. Louis, Missouri. St. Louis is the most historical and interesting city that you may not know much about it, but I encourage you to get more information and come and visit. We here at Washington University are open to visitors from all over the world. So without further ado, I just want to get the introduction to this talk. The subject title is Expanded Hemodialysis and Clearance of Large Middle Molecules. And I just want to start with what I consider the historical perspective on this. Just giving you a vignette of an example from another discipline. Let's say the patient comes to see the oncologist, and the oncologist tells the patient, well, you have a malignancy, you have multiple myeloma. And for you, we have the best possible therapy circa 1985. And this is just the latest that we have for you. Of course, this is a completely ludicrous, ridiculous assumption. No oncologist and no oncology patient will stand for that. However, if you look at the parallel of disciplines, this is pretty much where we are in nephrology. We stop the latest advance up to now in the treatment of end-stage renal disease and how is it that we clear molecules on hemodialysis, stop around 1985, 1986. And now we have, I would say, a revolutionary possibility to move the discipline forward. So, sorry for it. This is a non-promotional, non-branded talk, and I'm a contracted speaker for Baxter. I receive an honorarium for this presentation. So the roadmap today will include what I consider a review of the classification of uremic toxins. What are the adverse effects of large middle molecules? And I will go in particular detail about the definitions of what large middle is. What is the current state of the art between dialyzer membrane versus the real McCoy, the real kidney function? And what is the current state of dialyzers of this new advanced equation, which is the medium cutoff membrane innovation ones? So if we look at what is ailing and killing dialysis patients, there is no question that cardiovascular disease is over 60 to 70% of all the demise of patients on hemodialysis. And this is a summation consequence of a lot of hardening of the arteries, arteriosclerosis, severe endothelial dysfunction, myocardial fibrosis, and coronary artery calcification. This is all the things that piled up against a cardiovascular patient. The mere diagnosis of end-stage renal disease entitles a fourfold increment on cardiovascular risk factors. And what we have found over the last 20, 30 years is that we really have a significant amount of uremic toxins that we have not been able to clear or not been able to deal with. Oxidative stress is a great issue in terms of affecting patients on dialysis, and the inflammatory conundrum is another part of this equation. At the other side of the spectrum, we have the chronic kidney disease, metabolic bone disease, and we have a lot of elements that are very much increased on end-stage renal disease, such as fibroblast growth factor 23, and another ones, protectors are decreased, such as clotho. So all of these, I think, as I said, piled up against dialysis patients, bringing about this cardiovascular morbidity. We wish to send our patients a message of hope and optimism, but the reality of it is quite painful because patients don't realize that their life expectancy is sandwiched anywhere between what colon cancer patients and lung cancer patients is right in between them, and is significantly lower than if you receive a renal allograft, a kidney transplantation. 5-year survival for incident new dialysis patients is worse than cancer, and that is a very damning issue, an indictment of the nephrology and dialysis community. Again, going over this, the compilation of inflammation, atherosclerosis, vascular calcification, the increment of surplus of uremic toxins that we have not been able to clear lead to all of this, and the fact that up to now current therapies have had a very, very limited capability to remove all those toxins that we left behind. So if we look at what is the physics of how do we remove and the evolution of the dialysis membrane in terms of what we have been able to do, we have here a graph where we plot the very first generation of dialyzers, the low flux dialyzers, as opposed to the state-of-the-art high flux dialyzers, the ones that came about 1985 and is what the renal community uses at the present time, compare with the natural glomerular basal membrane. And what you see here is a plot of what at the upper end, molecular weight retention offset, or MWRO, which is the point in which you don't have any more free clearances of substances and you start to be selective. So the MWRO is when you start clearing. At the other end of the spectrum, you have the molecular weight cutoff, or MWCO, which is the point where you're not filtering anymore. So this will be a 0.9 when you start this curve, and this be a 0.1 when you cannot remove anymore. And you notice here that for low flux membranes, this is a steeper curve. As you get closer between the molecular weight retention onset and the molecular weight cutoff, you get a more vertical line. These two approximate each other, the ideal being the glomerular membrane. So high flux membranes were much better than low flux membranes, and that led to incredible advances in the care, in the clinical care of dialysis patients. We see here the forces. Any nephrologist worth their salt, I think, knows this perfectly well, that there are the two forces that combine to make up clearance are diffusion and convection. And diffusion takes the lion's share of the clearance for very small molecules, an example of that being urea. You see here that I would say 80–90% of the clearances urea is done by diffusion, and only small amount is by convection. Diffusion characterized by just crossing across a pore and osmotic balance in both sides, whereas convection is a more complex form that depends on the uh, architecture of the filter, the the type of membrane, the size, the osmotic forces that you put, the also the hemodynamic pressures that you add. And compared to urea, you see here B12, which is a paradigm example for middle molecules, in which the diffusive and convective forces are kind of even, 50% each one. And this compared with a large, bulky vegetable starch, inulin, in which convection takes the lion's share here, 90% of the removal, and being very large particles don't cross easily the course of the dialyzer, and diffusion takes only a very, very small part of it. So looking at the evolution of the standard of care, I think the history of hemodialysis is very, very interesting. And we made great strides in the late 1960s and 1970s. But we have the very first generation of dialyzers made of spun cellulose and cuprophane. Those were dialyzers on the mid 1970s up to 1985. And you can see here that the removal, the area of removal for low flux membranes will allow for some vitamins and urea and creatinine to be removed, whereas beta-2 microglobulin is very much at the very end of the spectrum. So this is the stuff that early on dialysis you could not see, you could not remove, and that would stay behind. So I think one of the reasons I am the speaker for this talk is because I've been doing this for a long time. And I belong to the generation that had for close to 5 or 6 years of my early life as a nephrologist, a witness of what this membrane will have as a consequence. Every single one of the patients I took care early in my career were completely hunched over. They have incredible amount of pain in their joints. They have a lot of bone disease. Literally, you look at x-rays with big holes in their bones, and all of this because beta-2 microglobulin will agglomerate into amyloid, and amyloid arthropathy was what ailing those patients. A dialysis patient a mile away for the way they walk and the way that they were having so much bone deformity. The advancement of high flux membranes in the 1980s ended with that. And the reason for it is that instead of being here at the end of the spectrum, high flux membranes were very good at clearing beta-2 microglobulin. And we cure that disease. We cure amyloid arthropathy. And this is many patients stop dialysis because they couldn't deal with that pain. And that's something that the evolution of this membrane was able to deal with. And at the end of the spectrum, we have now the next frontier, larger membranes, such as larger substances, such as myoglobin, that were able to start to get clear. So the understanding of this evolution from low flux to high flux to the idea that you had to increase clearance of all these middle molecules to get better results. And that has been recently very much validated by a good randomized study where we have what is called online hemodiafiltration. Online hemodiafiltration allows for increment of the convective forces in a great manner in which you do pre and post dilution. You have to have a huge amount of volume to carry all of these molecules, require very, very sophisticated, specific both machines, hardware, and sophisticated nursing, very expensive. And that is the reason that that has been only taken hold in a few places in Western Europe and only on clinical trials in the US. But this could never be scaled up into everyday practice. So expanded hemodialysis is a way to replicate this, and if anything, improve on that. You see here that with the new dialyzer membranes, you have the myoglobin that here was at the end of the spectrum with high flux, now is right in the middle, and the very edge frontier of it will be albumin. And beta 2 microglobulin is very much removed, uh, even better than the high flux membranes. So what is expanded hemodialysis? Is the dialysis treatment where diffusion and convection are both combined inside a new whole fiber dialyzer that has a very high retention onset, defined as a medium of membrane. And the really advantages of this is that does not require any particular hardware. All the existing dialysis machines are able to accommodate these filters, does not require any change in quality or quantity or no training because it's essentially changing your dialyzer filter. Expanded hemodialysis, most important because you want to look at the downside of everything, is able to maintain albumin levels while targeting the removal of these middle molecules, the large middle molecules, which are, as I will demonstrate, linked to a great degree of the morbidity and mortality of patients in terms of causing inflammation, cardiovascular disease, and other symptom-related comorbidities that are very, very important to patients. So this is a little bit confusing. So I want to spend a minute of that. So we have large middle molecules, we have small molecules, which is the ones at less than 500 kilodaltons. And this is what we were able to meet in the first decade and a half of dialysis with the low flux dialyzers. Then we have among the middle molecules, these are small molecules, among the middle molecules, we have three different distinct categories. Among middle molecules, we have small, medium, and large middle molecules. So small middle molecules up to 15 kilodalton, this is something that the current prevalent dialyzers, the high flux dialyzers, can reach up to this frontier. But this is where it stops, around 15 kilodaltons. Medium middle molecule weight solutes are the ones that are from 25 kilodaltons, and we cannot reach most of them at about 20 kilodaltons. Large middle molecule weight solids, 25 to 45 kilodaltons. And just to remind you that albumin is about 60 to 65 kilodaltons, is what we remove. And other protein-bound solutes are the ones, such as albumin, that are a little bit larger in size. So when we look at the classification of uremic toxins, I think we have all kinds of new definitions and classifications. We're going to talk a little bit, an illustration of the clinical relevance of these middle molecules and review some of the membrane characteristics. So here illustrates in this graphic examples. There are many more, but this is the paradigm example. So molecules up to 500 kilodaltons, such as urea and phosphate. And I think once we were able to remove that, we dealt with uremic toxicity and with the vascular calcification or ossification caused by phosphate, removal of low flux membranes, dealt with this in a fairly effective manner. But we have then things left behind. And you have small middle molecules such as PTH and beta 2 microglobulin that were more or less deal poorly. And not until we have high flux dialyzers, we were able to remove that in a more efficient way and do away with these noxious uh, 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 joint amyloidosis. So what are medium membranes? I think some examples are there. Just these are only a few out of maybe 30 or 40 medium molecules staying behind is myoglobin, which accumulation of such causes a lot of oxidative stress and mitochondrial dysfunction. Kappa free light chains, which are uh, connected to multiple toxicities in terms of symptom-wise and in terms of immune responses. Complement factor D, another new player that is very much heavily pro-inflammatory substance. Interleukin-6, which it causes a lot of the symptoms of patients have, such as pruritus, recovery time from hemodialysis, chronic inflammatory disease, cardiovascular disease, a whole pile of things that affect our patients. Finally, we have uh, middle molecules such as tumor necrotic factor, which is activated and out of control in sepsis, uh, uh, responsible for a lot of chronic inflammatory conundrum and protein wasting. Fibroblast growth factor 23, familiar to many nephrologists, uh, responsible also for secondary immune deficiency and cardiovascular disease. Alpha-1 microglobulin, responsible for symptomatology that vexes patients such as restless leg syndrome. YKL40, this is kind of the peptide of the year in rheumatology, a pro-inflammatory substance also that has been connected with a lot of morbidity. And finally, lambda-free high chains, light chains, also causing secondary immune deficiency. Of these are able to be removed by the medium cutoff new advanced technology therapy on hemodialysis. And all of these dialyzers hopefully do not reach the undesirable part to get up to albumin 60 to 69 kilodaltons, which is what you do not want to be removing. So what is the evidence that these uh, large middle molecules have a negative effect to patients? These are several observational studies. For many years, I felt that CRP or C-reactive protein was a marker of inflammation, and it was just a weather vane telling you where you are in terms of the inflammatory conundrum. It turns out that if you are able to remove CRP itself, uh, maybe along with other substances, makes a big difference in terms of survival. We have here just a graphic telling you a prospective study of 91 patients, where patients were stratified between a very high CRP, middle of the road, and very low CRP, middle of the road, and very high. And you see here that the cumulative survival plummets with a very high CRP. And it's been demonstrated that whatever you do to decrease this number in terms of removal, specifically of CRP, will be of benefit. We have, in terms of this important molecule, YKL, the 40 implies 40 kilodaltons. So this is a medium to high size medium molecule in which we see here that probabilities of all-cause mortality or cardiovascular mortality related to a very, very high level of YKL or a very low level of that, telling you that there is a very linear plot in terms of mortality and the level of this enzyme, this substance, this peptide. These are a very large number of dialysis patients that were studied. These were all the substances that were demonstrated. And so there was a significant differences between the high and the low. Here we see another example where we see kappa-free light chains and lambda-free light chains that positively correlate with surrogate for cardiovascular disease, aortic calcification, and mortality. We have here for the kappa, here for the lambda, and you see that in terms of overall cumulative survival, significantly better when you have low kappa chains, significant less aortic calcification and overall survival with the lambda chains. And this again is a pretty good study of 133 end-stage renal disease patients. We see here in terms of symptomatology and the restless leg syndrome, a relationship with another potential noxious agent, alpha-1 microglobulin. And we see here what happens when you're able to remove these. The alpha-1 microglobulin at this level between 20 and 30, very high level, is unable to cure the international restless leg syndrome score compendium, very high. And still, when you are down to the 10, patients are still complaining. Only when you get to a 40% removal of alpha-1 microglobulin, you quiet the symptomatology for patients. So let's switch gears here and talk about dialyzer architecture and the comparison with the glomerular membrane. Just to remind, this is the cartoon of the glomerular capillary, and we see here that each kidney will have, ideally in life, about 1 million glomeruli with a total surface area of about 1.5 meters square, and a total filtration, which is astounding what the normal human kidney can do, of 180 liters of fluid per day. Compared with the dialyzer membrane, you have each dialyzer field contains between 10,000 and 15,000 hollow fibers with a surface area that approximates what you have in terms of the kidney, 1.5 meters square. The difference is that instead of having 7 days a week, 180 liters a day filtrate, over a period of, let's say, 3 to 5 hours, your total filtrate, the chance that you have on the occasional dialysis, is only 2 to 4 liters of filtrate a day. If you look at what are the characteristics that define a dialyzer, you have to have these definitions here. Pore density is the number of pores divided by the membrane surface. And this is something that the technology and the design of dialyzers have gotten very, very much sophisticated. In the Stone Age, when we were using spun cellulose acetate, the pore density was very low, and now we're able to manufacture dialyzers with a very, very high density. Pore size determine the maximal size of solutes. It stands to reason that if you have larger pore size, you will be able to remove larger molecules, and so convection forces will be increased. Larger pores will be much better than in high flux membranes than in low flux membranes. Pore size describes also the uniformity of it for the pore size distribution, because I think also as the technology have improved, we're able to remove larger number of substances by increasing the uniformity of the pores. If we compare the present generation of dialyzers, the high flux dialyzers, we see here, once again, the beta-2 microglobulin is here. At the very end of the spectrum is myoglobin. With the new medium cutoff dialyzers, we see here that myoglobin have moved towards the center. We're able to remove, and at the outer frontier is albumin, which is what you don't want to remove. So beta-2 microglobulin have moved from the middle of the page to the beginning. Now, this is not a challenge to remove. This is a disease that hopefully we'll never see again, amyloid arthropathy. And myoglobulin, which is a harbinger of many other molecules, is right in the middle of the pack. So if we explore the clinical relevance of this, I want to bring the definition of all the different dialyzers we have. We have low flux, I spoke about it, the current generation of high flux, the new iteration of medium cutoff dialyzers, and then we have another one that I didn't speak of, high cutoff dialyzers, the ones that have very, very large pores and are specifically designed to remove molecules above 60 kilodalton. So what are we doing here? Well, these are for specific reasons for patients that have multiple myeloma and require removal of that. And so these membranes will be removing albumin because they're designed to do that, high cutoff. So these are kind of a very narrow niche of dialysis, not designed for dialysis patients. But if we compare what is the number of pores and the pore size in low flux, we see that it's all over the map. Pore size and number, low pore size, pore number, I'm sorry, and very wide distribution of pore size. High flux membranes change this, and now we have a narrower pore size and a larger number of pores. The medium cutoff membranes, what this new technology has advanced, is that now these have a very narrow spectrum. Pore size are far more uniform. Pore numbers are much higher than high flux. And this allows for this discrete narrow band that ends before you start losing significant amount of albumin. So 27 large minerals have been identified, and all of these are things that are responsible for a lot of the chronic inflammatory conundrum, protein wasting, cardiovascular disease, left ventricular hypertrophy, and immune deficiency. So what is then the rationale and what is the practical aspect of expanded hemodialysis therapy? We see here a graphic where we compare the reduction rates for various middle molecules, comparing a high cutoff dialyzer with a high flux dialyzer, and either for beta-2 microglobulin, myoglobulin, kappa free light chains, factor D, alpha-1 microglobulin, YKL-40, or lambda free light chains. For all of them, we see that medium cutoff dialyzers are superior than the existing technology of high flux. So expanded hemodialysis removes effectively large middle molecules linked to inflammation, cardiovascular disease, and other dialysis comorbidities. We see here at the other end of the spectrum the safety of it. We have here on the first graph serum albumin over time, from time 0 to 32 weeks, and we see that you lose some albumin, but at the end of the spectrum remains the same. And I think I just want to spend a minute about it and put this in some perspective. On a conventional hemodialysis with a high flux dialyzer, we lose about 2 to 3 grams of albumin. So in a cumulative, let's say at the high end of this, you're losing about 10 to 12 grams of albumin a week on high flux dialyzers. Here, because you have moved the line a little bit further down, you lose a little bit more albumin. You're losing, instead of 2 to 3 grams per dialysis treatment, you lose 5 grams, 5 to 6 grams at the most. So 6 times 3, I would say 15 to 18 grams of protein a week. How does that compare with parallel therapies, such as peritoneal dialysis? on a very, very good day when there's no inflammation, no peritonitis, no chronic conditions that will increase your inflammation coefficient, a peritoneal patient is losing between 5 and 8 grams. So per week, that gets to a combination of close to grams of albumin. So no wonder that albumins on peritoneal patients are a little bit lower, but this is about 2 to 3 to 4 times as much in peritoneal dialysis that with any of these medium cutoff dialyzers. And I think most important is that the serum albumin, which the body was able to compensate. And when you look at the 3 months, 6 months, 1 year, serum albumin is no clinical significance decline on that. When you look into changes at 4 weeks, at 32 weeks of the stuff you want to remove, you see there is a significant drop both in lambda and kappa chains by 1 year. Here is the removal of middle molecules, a multi-center observation in which we see significant decreases on all the things that you want to remove with medium cutoff dialyzers: beta-2 microglobulin, myoglobulin, kappa, lambda chains, CRP drops significantly. But you see the serum albumin at 3 months and at 6 months compared with baseline is virtually unchanged. So this is exactly removing all the stuff that you want to take out without impacting in any clinical significance your serum albumin. We see here another study where we see medium cutoff dialyzers in a very large population of hemodialysis patients. This is a group of close to 650 dialysis patients for a year and a half, comparing expanded hemodialysis medium cutoff dialyzers with Flux, Revaclear, the state of the art for most dialysis units around the world. And we see results. The variable in serum albumin was only a 5% from baseline, and this was maintained about the same. So by 12 months, it was only a decline of less than 1.8% on serum albumin, something that I consider rather trivial. We see here what is most important to patients, which is what is the compendium of symptomatology. In this study, we have a 12-month study in 58 dialysis patients comparing hemodialysis, high flux hemodialysis with expanded hemodialysis, the medium cutoff dialyzer, in which we study symptom of 17 of this score, the palliative core care outcome scale. And we have a baseline, we have pre-post dialysis, and then we have at 3 months, 6 months, 9 months, and 12 months. And the results is by 6 months, the amount of symptoms and the recovery time of dialysis. Just to remind to whoever is not familiar with this, recovery times is a very kind of significant complaint of patients. They finish their treatment and they go home tired, they have to go to sleep. Recovering time is maybe anywhere between 2 and 4 hours. We see that at 6 months, recovery time went down in a very, very significant way. By 9 months, this was sustained. And by 12 months, this was maybe not as good, but it's still on the medium of it was much better than baseline. So in a randomized controlled trial, we see the difference between medium cutoff and high flux membranes in the quality of life outcomes in dialysis patients. This was in 50 patients, and we look at the physical domain, mostly looking at another thing that really symptom of most prevalent of dialysis patients, uremic pruritus, with the hypothesis that removal of many of these substances will cure itching on these patients. And we indeed saw the putative bad agents for these, kappa light chains and lambda light chains, decreasing in a very significant way. Once again, we see no significant changes in serum albumin. There no between the two groups. What is important is when you look at the uh, uh, frequency of scratching, waking up during sleep, surrogates for patients that are uncomfortable and itching, was significantly better on the patients on the medium cutoff dialyzers. So this membrane improved quality of life outcomes in various physical domains on what is really relevant to the quality of life of our patients. Another part of this, again, for this very large study, 642 patients for 12 months, where they're looking at QD, KDQL 36, the dialysis symptom compendium, restless leg syndrome, and you compare the values at the onset, 6 months and 12 months. You got to take my word for this. These are all were significant differences on all of that. And proportion of patients who met the restless leg syndrome criteria decreased more than 50% on patients receiving this medium cutoff dialyzer membrane. The compendium of dialysis symptomatology decrease in severity between 6 and 12 months. So with this, I just want to close, and I say that now I think we can safely say that in a kind of a very practical, pragmatic patient, we have the next turn on the evolution of hemodialysis. In the same fashion that on my watch, I was able to see that improvement on dialysis membranes did away with a lot of symptoms that were ailing our patients in the early 1980s. We have now the next generation of membranes that can, the next frontier, that can remove all other substances that we have not been able to remove. And I think if you read the last year's New England Journal of Medicine, comparing hemodiafiltration in the few places that are able to do it, comparing with conventional high flux. Now, there is no question in this randomized trial that hemodiafiltration is superior in terms of decreasing mortality in dialysis patients and significant morbidity. Is my contention that this is going to be not only proven the case with medium cutoff membranes, but it actually can be improve upon what hemodiafiltration can do. Based on other studies have demonstrated better clearances of all these substances with much, much less cumbersome treatments. With this, I will close the formal part of the discussion, and I'll be happy to entertain any comments or questions that you may have for me. Thank you so much.
Thank you, Dr. Ralstein. Corey has shown the first of the questions here that are in our pigeonhole. If you want to go ahead and answer this, it is, how does the HDX dialyzer accomplish convection using a traditional IHD machine?
I think this is exactly, thank you for this question, because this is exactly what you can have your cake and eat it too. You don't need to change any kind of the present equipment. With putting the ultrafiltration forces on a regular dialyzer, on a medium cutoff dialyzer, is exactly the same. Is the secret sauce is inside the hollow fiber, the uniformity of pores, the size of the pore, the thinner membrane, all of that plots to improve convection using exactly the same machine. You can be living in Malaysia, Malawi, or Mexico, and you still can accomplish all of this just by virtue of changing your dialyzer.
Excellent, thank you. That happens to be the only question that we have in Pigeonhole right now. The Pigeonhole QR code, please log in and enter any questions that you might have for Dr. Rothstein. Or if you have questions and are unable to access Pigeonhole, you could go ahead and put those in the chat as well. We'll give just a few more moments here for anyone to enter in any questions, Dr. Rothstein. Thank you so much. Corey, if you want to go to the next slide while folks are entering their questions, we can talk about the remaining webinars in our series, the Kidney Month Spotlight webinar series. We'll continue next week with a spotlight on peritoneal dialysis. And then the very last week of the month, Dr. Rothstein will be back to talk about the utilization of CRRT with brain dead donors. So that interesting connection to CRRT between CRRT and transplant is coming up in just 2 more weeks. I do not see any additional questions in the Pigeonhole. And with that, if no one else has additional questions, we'll conclude the webinar for today. I appreciate your time and your expertise, Dr. Rothstein. And you go ahead. Do you have?
Thank you very much for the audience and the privilege of bringing this important subject today.
It's absolutely very important. Thank you so much. And we'll go ahead and conclude the webinar for today. Have a wonderful afternoon. Bye-bye.